Okay, welcome everyone. Let's start. There may be some other people joining us during my introduction, but I'm very happy to welcome you all to this first webinar organized by Action on Preeclampsia Ghana in collaboration with the SPOT studies, a study initiated to improve the care for women with preeclampsia in Ghana. And the theme of this first webinar is management of hypertensive disorders in pregnancy. And today we'll focus on prediction and management during pregnancy. There will be 2 other webinars in the next 2 months where we'll focus on other topics, and we'll make sure that you receive all the information about those as well. Today, my name is Joyce Brown. I'm Assistant Professor in Global Health and Epidemiology at the University Medical Center Utrecht in the Netherlands, and I have the privilege of moderating this first webinar. I would also like to welcome the other members of the organization team here today, and especially our 2 speakers. Dr. Kwame Adebonsafa will start with a general introduction about preeclampsia and focus on prediction, and Dr. Mano Sofreño will discuss the management aspects. A few practicalities before we start. Please ensure your microphones are muted. That is the default setting we have at the moment. If you do have a question, please indicate this in the chat. We can then invite you to ask your question or ask your question on your behalf. And please note this meeting will be recorded and available online through the APECGH website and social media platforms. And I would also like to warmly welcome people who are viewing this as a live stream on Facebook today, because some of you are seeing and learning about this meeting this way around. The recording will be made available after, so if you miss parts because of your internet connection or others who are interested to learn about this, there will be an opportunity to watch this later. So this is the program. As you can see, we will have, after an introduction of speakers, we will have 2 presentations followed by a Q&A. And as you can tell, the time for the Q&A is quite long, because we really want to encourage you to ask all the questions you may have regarding the topic. As was also circulated, this series and this webinar is CPD accredited, and we will share the forms where to apply for accreditation at the end of this meeting, but also by email after. Vivian, can I invite you to introduce the speakers?
Okay, thank you very much, Joyce. Welcome everybody to today's webinar. We're excited to have you here. Our presenters for today are 2 very distinguished and learned persons in preeclampsia and management of hypertension in pregnancy. First on our list is a lecturer with the Department of Obs and Gynae at the University of Ghana Medical School. He's also a consultant at the Kolebu Teaching Hospital. He did his fellowship in Obs and Gynae at the same hospital, and he has an MPhil in physiology. He's done extensive clinical and research experiments in the field of maternal health, fetal medicine, and management of hypertension disorders in pregnancy. He has a special interest in maternal fetal medicine, preeclampsia, and preterm birth. He's in the person of Dr. Kwame Adebonsafa. Our second speaker for today's webinar is in the person of Dr. Emmanuel Sofreño. He's a fellow of the West African College of Surgeons and a foundation fellow of the Ghana College of Physicians and Surgeons. He's also a consultant of Gynae personnel and has an MPhil degree in health services management. He's been the head of the Obs and Gynae department in the Greater Accra Regional Hospital and at Ridge. We welcome them both. As Joyce has already said, Dr. Edubon Safo will be taking the first presentation, and Dr. Srofenyo will be taking the second presentation. Thank you.
Thank you. Dr. Bonsafo, can I invite you, yes, to share your screen, and the floor is yours.
Right, thank you for the introduction. And first of all, I want to take this opportunity to say thank you to the organizers and the executive for inviting me to speak on this platform. So the title for today's meeting on my part will be to talk about the prediction of hypertensive disorders in pregnancy. In most of the talk, we'll be dealing with pre-eclampsia, since that is the main prototype of hypertensive disorders in pregnancy. So by way of presentation outline, I'll briefly talk about the introduction and a brief on the classification, a little bit of pathophysiology and prediction, and then we can conclude. So by way of introduction, as we know, hypertension in pregnancy is the most common medical condition in pregnancy, and it's associated with significant maternal and perinatal deaths. If you look at the fetus is more affected because we lose a lot of babies as a result of the condition. And in Ghana, for instance, this has also contributed significantly to the maternal mortality ratio, and now it's around 308 per 100,000 live births. Comparatively, we can see that we are still very far from the main point when we compare ourselves to the high-income countries. So in Ghana, we all know that, I mean, it's accepted that hypertensive disorders is a leading cause in the teaching hospitals. However, what I want us to draw our attention to most is the fact that over the 10-year period, looking at the maternal, Ghana Maternal Health Survey from 2007 to 2017, we can see that hypertensive disorders has actually doubled from 9% to about 18%. And this tells us that even though there's overall reduction in maternal death, the relative proportion is doubling, and we need to look at it. Comparatively, when we look at the Netherlands, where actually the maternal mortality is one of the lowest, it's around 5 to 6%, 5 to 6 per 100,000 live births. A study indicated that most of the deaths, I mean, the commonest cause of maternal deaths is actually hypertensive disorders, and most of them are due to substandard care. I think that if we relate it to Ghana, a developing world, we might be clicking somewhere more than 100%. And this slide gives us a summary of the classification, but I'll just limit ourselves to pre-eclampsia, which you can see here. All the others are associated with significant mortality and then morbidity, because the current definition or classification includes chronic hypertension, and then that can be can result in superimposed pre-eclampsia. However, there's a new definition which I think we should point to, something like the transient gestational hypertension, which is the situation where one develops hypertension but does not require treatment and it resolves spontaneously. That is a transient one, which is different from the gestational hypertension, which requires treatment. This is the current definition from the International Society for the Study of Hypertension in Pregnancy. And it is now recommended that we should avoid using a PIH because it means differently to different people in different worlds, and we have to take note of that. In Kolebu Teaching Hospital, it will surprise you to know that in one of the studies that we did, 1 in 5 women presenting at the obstetric department actually had hypertension, and preeclampsia occurred in about 7.5%. And this tells us that we should be mindful of it. However, we had a lot of them, most of them were gestational hypertension, but we know that sometimes gestational hypertension will also result after some time in preeclampsia. I brought in this slide to remind us of the fact that very soon, maybe we might be seeing our classification definition of hypertension in pregnancy moving from the 140/90 that we know to about 130 to 139 and then 80 to 89. This is a recent recommendation from the American Society of Cardiology. So to talk about prediction, it will be important for us to look at, a little bit about the pathophysiology that will help us to relate to what the disease is, and then we can try to prevent it. This diagram shows us, you can see from here that there are a lot of factors, genetic, then you can have environmental and immunological factors. However, these factors can lead to abnormal placentation where you have failure of the physiological transformation of the spiral arteries. And therefore, the spiral arteries actually retain the ability to contract when they respond to vasoactive substances in the blood. And so it can lead to oxidative stress, inflammatory exudate, and other substances leading to overall systemic vascular dysfunction. And some of these factors, one of them that I think we should take note of is the vascular endothelial growth factor and then placental growth factor. The two of them actually work together by helping with angiogenesis. And if there's a problem with the placental growth factor or vascular endothelial growth factor, then you can result in preeclampsia. So from what I said, this is a situation where you have a first trimester where the spiral artery is being modeled to become widely dilated, which will prevent recurrent contractions to reduce blood supply to the developing embryo. So you can see from here that there's a placenta of a preeclamptic person. However, in the normal development, you will see that it has been dilated well, and this will allow adequate transportation of blood to the developing embryo. And this slide also tells us about the fact that even though we always talk about the dilatation of the spiral arteriole, initially there's a plaque formation that actually blocks it. This leads to kind of some form of hypoxia around this area, and this is actually critical for development of the placenta and then the arterioles, spiral arterioles. When this trophoblastic plaque is impaired, it leads to early miscarriages and early onset preeclampsia and others. But the problem is when there is this reduction in placenta perfusion, as we can see, it leads to maternal syndrome, which is a preeclampsia, but we don't know exactly what causes the link, because we know that there are a lot of women who also experience reduced placental perfusion, but do not go on to develop maternal hypertension or preeclampsia. And that is what we need to look out for. And it turned out that there's not like a constant reduction per se, but there is an intermittent perfusion of the placental bed, which causes the placenta to become kind of confused and elaborate a lot of factors that can cause endothelial dysfunction. And so that is responsible for the main problem. And here we are talking about oxidative stress, which is leading to recurrent or on and off release of blood to the placental bed. And this is something that we have to talk about, because you can see that there is hypoxia and re-oxygenation or ischemia reperfusion kind of injury. So it's not the constancy of the reduced perfusion, but the irregular release and then or irregular closure or opening of the placental bed that can cause vascular damage at the placental bed as well, and leading to frustration on the part of the placenta and the fetus. So angiogenic factors, as I've mentioned, have been implicated, and the main ones are the placental growth factor and then the VEGF that I mentioned. So it turned out that this VEGF that you can see here, and then the placental growth factor are the one that will react with or combine with the receptor to lead to adequate production or development of the placenta. If this is impaired, you can see from here, this is the structure which we call soluble flight 1 that binds to these two useful substances. And when it occurs like that, it prevents these useful substances from binding to their receptors, and that can result in development of abnormal placental flow. And this is one of the things that have been used in terms of prediction. So you realize that we did a study using this placenta vascular endothelial growth factor levels, and we realized that there was significant reduction in people who developed severe preeclampsia. And similarly, these vascular endothelial growth factors lead to production of nitric oxide, and similarly, they were elevated, and that might be due to compensatory mechanisms trying to dilate the vessels to produce more blood flow to the fetus. For us we need to remember that pregnancy is actually considered as something like an accelerator and a brake system, where if you don't have the braking system, then the system will lead to the development of preeclampsia. And it turned out that in the body, we are supposed to have adequate amount of carbon monoxide and hydrogen sulfide. And these are braking systems which can cause the level of the placental growth factor here to be high. And therefore, this will lead to vascular protection and normal placental growth and then normal pregnancy. If this is not there, then you get vascular damage and resulting in preeclampsia. So having talked about the pathophysiology, looking at the placental growth factor levels and vascular endothelial growth factor levels and the others, then it brings us to actual prediction. And the problem is that a lot of predictions have been done using single tests, multiple tests, and history and all that. But I want to stress here that currently, we are not thinking about a single test that can predict, because studies have shown that it is difficult to get a single test to predict preeclampsia. And what we need to think about is a multivariable prediction model where we build on we build from the maternal characteristics, add examination findings to it, and then you can now add laboratory tests. So in that case, we will be thinking about the added value of a biomarker or a test to the maternal characteristics, and that can help a lot. And so a study was done by one of our own, Dr. Entry, and Joyce was also, I think Joyce reviewed this paper as well. But this study actually showed that they did a systematic review, and it turned out that there were about 40 prediction models of gestational hypertension and preeclampsia. But most of them were done in the developed world, and then only about 2 to 5 were done in low and middle income country. And most of them actually combined these biomarkers that I talked about. And you can see the added placental growth factor level and then pregnancy associated plasma protein. And most of this, the problem with this, what they found was that most of these prediction models did not actually follow the standard prediction rules. Like, we have specific guidelines to use for prediction models, but most of them actually did not follow it. And therefore, it makes it very difficult for us to use this kind of predictions in the real life. On the other hand, you can see that based on that, it will be difficult to have, and there is actually none. There is no single first trimester or second trimester test that can reliably tell us about somebody who will develop preeclampsia. And so we should not be thinking about a single value or a single test to rule out preeclampsia per se, even though we know that placental growth factor may have a very big role in future, but for now it's a little difficult. The idea is that the International Society for the Study of Hypertension in Pregnancy recommends that if we can use some of these strong risk factors, there are strong risk factors or major risk factors, if we're able to identify women with those risk factors, this will be maternal characteristics or history. then we can start them on aspirin before 16 weeks and definitely before 20 weeks. So based on those characteristics, the society actually came out with these factors and considered them as major. One of them is somebody who has developed prior pre-eclampsia, chronic hypertension, pre-gestational hypertension, and the others. And these are the minor risk factors. So if we see anyone with any of these major risk factors, it is recommended that we consider giving them aspirin, and you can give up to 150 milligrams daily, starting at least around 16 weeks going. And these findings were based on the odds ratio and relative risk that were calculated from a study that was done in about 2013. So based on that, to develop a prediction model, it has to be very simple, innocuous, it should be reliable, non-invasive, inexpensive, and it has to be rapid so that we can look at it and help with clinical diagnosis. And in the end, it has to also be valid, reliable, and reproducible. So somebody elsewhere can also look at it. So having said this, it's important to know that to have a prediction model, you need to look at the preconception factors, which are the risk factors mainly that I mentioned. And then you can ask, or you can add the biomarkers to it. And here, the first step in the management of a woman with a history is to kind of take a very good history of the potential risk factor that we have talked about. And it will surprise you that there was a large systematic review that used parity, previous history, race, and other factors to predict preeclampsia. And then the area under the curve was about 0.76. This is good, but not very, very good in terms of we still have some, we may still lose some patients if we use this. This tells you about the difficulty in getting a prediction model. More recently, that was the one I was trying to refer to, where Dr. Entry and Joyce, they did a study in Ghana and then tried to predict. This one, they used our own, I mean, I wanted to bring something that was done in Ghana as well so that we can talk about it. Use our own data in Ghana, study was done in Ghana and predicted gestational hypertension based on this kind of scores. And so these are the main factors that they found: parity, weight, height, diastolic blood pressure, and then gestational hypertension in the previous pregnancy and the history of hypertension in parents. And based on that, they classified it into women into low, moderate, and high risk. And you can see the figures there. And so this is something that at least we have in Ghana that we can also use to, as our women come to antenatal, they start antenatal, we can use some of this to kind of categorize them and monitor them in the antenatal period. So based on that, you can see that chronic hypertension can be as much as 40% risk of developing preeclampsia. And you can see all the way pre-gestational hypertension and gestational diabetes and the rest also coming in. Then after the preconception factors, we have pregnancy-related factors as well. And this, you use somebody who has a hydrops, multifetal or multiple pregnancy, unexplained intrauterine growth restriction, and gestational hypertension. You can use some of this and add to the risk factors and then increase the predictive value of preeclampsia. There are a lot of factors, and the red ones are something that we should, mean arterial blood pressure is something we should consider. Unfortunately, most of our studies and most of our clinical situations, we don't measure or calculate the mean arterial blood pressure. But studies are showing that it's very important, even than the systolic and then the diastolic blood pressures, and we should be looking at that as well. Then other factors have also been mentioned, and then you can see that we have isoprostane, which is for oxidative stress. You can see uric acid and others. And in one of the studies that we did, we realized that isoprostane levels were very high, and that shows that there is, in those people who develop early onset preeclampsia, it was so high. And so this is one of the things that we can also add on in future. It depends on the environment or the situation or the region where the study is being done. Then biophysical factors. I mentioned mean arterial blood pressure, which is the one that most people use, and we should be thinking about adding that to our normal clinical routines, and not only looking at the blood and the diastolic and then the systolic blood pressures alone. And this is something that we should also consider. Repeated routine urinalysis, like checking of the urine, will not help us much in terms of prediction, but it's something that we do every day in Ghana. Maybe we should think about it as we move on. It can't help us much because in terms of the prediction models, it doesn't come in much. I need to still talk about uterine artery Doppler because that's one of the main things that is coming up in the world. And Professor Nicolaides in the UK and other people have done a lot of work with uterine artery Doppler studies. Professor Campbell was the first person to develop the idea of uterine artery Doppler, but now being carried on by Professor Nicolaides and his group. And you can see that these are the main things where you can have high pulsatility index and also notching of the artery. The artery waveforms in the first and then the second trimester. Even though we have said that it's very good, standing on its own is not good. It cannot do much. And so we don't expect people to just use uterine artery Doppler in prediction. In the study that was done by the same group, Nicolaides group, they realized that maternal characteristics at worst, if you even increase the false positive rate to about 10%, can predict only 51% of people who develop preeclampsia before 34 weeks, and you can see it decreases as you move on. Then when you add maternal factor and all the other, this is uterine artery pulsatility index, the ultrasound that I talked about, and you add mean arterial blood pressure, pregnancy-associated plasma protein, and then placental growth factor, it turned out that it could predict about 96% if you use a false positive rate of 10. If you use 5% false positive rate, then it comes to 93. However, overall, this combination can only predict about 54%. It tells you that it's good for early onset, but not good for overall prediction. Then more recently, Pedroso et al. Also look at the same things and realize that, well, if you look at prediction in terms of less than 32 weeks, then combining maternal factors plus all these things that I mentioned, if you add maternal factor to even mean arterial blood pressure, you can only predict 71% if you increase the false positive rate to about 10%. However, if you add all these other markers, mean arterial blood pressure plus the placental growth factor and the others, then for early onset preeclampsia less than 32, you can predict 100%. Remember here that removal of the mean arterial blood pressure got to about 82% at 5% false positive rate. And so these are some of the predictions that have been done, and you can only think of adding something to something. Like, for instance, all the time, don't let us forget about maternal factors. We should have it and add most of this. You can see that uterine artery uterine artery Doppler studies is constant in most of them. It can't stand on its own, but it's very good as it predicts up to about 82% when you go to about 10% false positive rate. And then if you leave it alone, 71% if you want to get high sensitivity. So I've already mentioned the 81% with respect to uterine artery Doppler, which a lot of people are using now. We have to be sure that we have to be mindful that it cannot help us totally, although when we add it to others, it can really help. And then you can see the characteristic waveform. There is, this is the first trimester and the second trimester. In the first parameter, you can see that there's a notch, early diastolic notching of the waveform. And then you can see there's a reduction in end diastolic blood flow also around that. So you can see a similar thing here. The notch is still not completely gone and it's still there. And these are things that you can use. Let's remember that these are really based on the androgenic and pro-androgenic factors that I talked about. So trying to get to the end, a recent study actually is a review or reviews, trying to look at screening for pre-eclampsia showed that uterine artery Doppler, which I mentioned as a standalone, cannot do much. And so we should not think about it because it has low sensitivity and positive predictive value. And currently, no single biomarker can also stand on its own. And we need to think about combined factors or combined predictors. More recently, even though we all know that everybody has mentioned that spiral arterial poor remodeling or incomplete modeling is responsible for the hypoperfusion and therefore preeclampsia. It turned out that a recent detailed review showed that incomplete spiral arterial remodeling alone is unlikely to cause the abnormal uterine artery Doppler waveform that we have always been talking about. This is because if it is, there is upstream anastomosis, and which could actually cater for the reduction in blood flow there. So it turned out that we should probably be looking at radial arteries. This is where you can see radial arteries and not the spiral arterioles, which is at the bed, because you can see that probably that is close to the uterine arteries, and that may be a factor more so than the uterine, the spiral arteries that we talked about, because there are anastomosis that could help to resolve these things. In trying to conclude, I would say that blood pressure monitoring is very important. As we move on, we should think about all the time, also consider recording the mean arterial blood pressure, because that is the one that has been used in most of the prediction models. And we need to know that it is still not consistent. And so we need to consider other factors in terms of adding something onto it. We can add some biomarkers or uterine artery Doppler studies to it. And we also have to remember that placental growth factor levels and other pro-androgenic and anti-androgenic factors also play a role. Most of these prediction are done within the first trimester. The best is like 11 to 13 weeks, but you can do also from 20 weeks to 24 weeks going as well. That means that we should also remember that preeclampsia can start from 20 weeks. And if you want to do it around 20 weeks, it might not help you much because it may not be useful because you can't add or you can't treat or give the woman aspirin that may be very useful in prevention. Also, we need to also remind ourselves about the abnormal placental remodeling that I've mentioned, that it may not be the constancy of the reduction in the perfusion, but the intermittent on and off release, that may be a factor that can also occur. And the International Society recommends that women with established strong clinical risk factors for preeclampsia should be given aspirin around 62 to about 150 or 160 milligram. And I want to still say that currently there is no clinically useful screening, a single screening test to predict preeclampsia. We always have to think about the combination of risk factors or the combination of the things that we mentioned. In conclusion, I want to say that etiology of preeclampsia and other gestational hypertension and eclampsia is still debatable. Currently, there's no clinically useful screening tool to predict preeclampsia, and we are currently trying to still find some way to help with managing our patient. But we know that if we're able to predict this preeclampsia very well, it will help us to manage them antenatally and know exactly when to intervene. At this point, I'll end here for my other presenter to present, and then later we can ask questions. Thank you very much. These are some of the references that I used. Thank you.
Thank you very much for your presentation. Before we move on to the next speaker, I want to invite audience, if there are any clarifying questions, this can be asked now. We will have more time for elaborate Q&A later. But if there are very urgent, if there are some urgent questions, they can be asked now as well. And Dr. Van Safa, I'm not sure if you can see the chat, but there are a few things.
I'm trying to see the chat, yes.
Okay, if there are no immediate questions right now, we'll keep them for at the end of this webinar. And let me share my screen because I want to invite the second speaker. Dr. Sofrenio, please, the floor is yours. If you want me to continue to the next slide, just let me know and I will click and pull up the next slide. Dr. Sofrenio, are you there? You're mute at the moment. I can unmute you. And if possible, it would be nice if you could turn on your video too, so we can see you during your presentation.
Okay.
Yeah, I can hear you now.
Okay, so let me also use the opportunity to welcome everybody to the program. This is a very good program for all of us. And I can see a lot of colleagues in the panel. The topic is advances in the management of women with preeclampsia. And this is going to be the outline of my presentation, a short introduction, preeclampsia pathogenesis and classification, control of acute hypertension, other management principles, risk prediction model approach, summary and conclusion. By way of introduction, in their quest to have a baby and bring joy to their families, women face a lot of risk. And one of these risks is preeclampsia, as we all know. The medical and socioeconomic burden of preeclampsia is huge, especially in our part of the world. Recent scientific advances have brought better understanding of the disease condition. For now, however, early detection of the condition and deploying appropriate management protocols is the mainstay in controlling the disease. A little bit on pathogenesis. Even though my colleague has talked about pathogenesis, we know that the pathogenesis is largely unknown. We have placenta invasion theories, exaggerated systemic inflammation theories, and immunological theories. There are two main pathological types that so far has been identified. And these are the early onset type, where the woman develops preeclampsia before 34 completed weeks. And this is believed to be mainly due to placenta problem. It constitutes about 25% of the cases. Then we also have late onset type, usually developing after 34 completed weeks or more. And it is believed that predisposing cardiovascular or metabolic risk factors for endothelial dysfunction are responsible for the overall exaggerated systemic inflammatory response. Most of the hypertensive disease-related maternal and perinatal mortality and morbidity occur with the severe and the early onset type. So what I'm trying to say is that most of the problems we have are with the early onset type, even though they are smaller greatest challenges. So when we compare the two, the early onset type and then the late onset type, we see that the two groups differ in a lot of ways. Intrauterine group restriction, fetal group restriction is more in the early onset type, maternal hemolysis, again, is more in the early onset type. Neurological complications for the fetus is also more in the early onset type. There are more severe and frequent occurrences of cardiorespiratory complications, again, in the early onset type. Joyce, I hope you are with me. I hope everybody is with me. Yeah. Then hematological complications, adverse and severe fetal-placenta complications are all more in the early onset type. And even when the babies are born, the babies of the early onset type have more complications than the late onset types. Next slide, please. So a lot have been said again by Kwame concerning the prediction. But apart from internal limitations of the prediction models that she spoke about, there are not enough, as we all know, there are not enough reliable preventive measures. Even though soluble aspirin has been mentioned and calcium supplementation has also been mentioned in some of the literatures, there is not yet enough reliable mechanism to deliver these on a scale to make a significant impact on the pre-eclampsia burden. So therefore, the only way out for us currently is early detection of the condition and improving the quality and the standard of care of the pregnant woman who has been affected. Next slide. So talking about classification of severity, because before you begin to manage a woman, you want to be sure at which point is this woman, how severe is the case. The traditional classification of severity based on hypertension and urine protein has suffered some setbacks. Urine protein on dipstick varies widely and often unreliable in predicting disease severity. So in those days, we say, oh, urine protein is 1+, 2+, 3+. These are no longer very reliable in predicting how severe the condition is. Protein in a 24-hour urine sample, though is more reliable, but we all know it's very cumbersome. It will mean that having to accumulate the woman's urine that he has passed by a whole 24 hours before you are able to determine the urine protein and have an idea of how severe her condition is. A systematic review of 16 studies for estimation of proteinuria as a predictor of complications of preeclampsia concluded that measurement of proteinuria is a poor predictor of either maternal or fetal complications. And consistent with these findings is the fact that in about 21% of cases, eclampsia even occurs when there is only hypertension without even any proteinuria at all. Because of this, as we all know, APECGH guideline 2013 stipulates that the diagnosis of preeclampsia no longer requires significant proteinuria. Various studies also suggest that hypertension and proteinuria are not even sufficient markers for severity of preeclampsia. We can have a situation where the woman's blood pressure is only, let's say, 140/90, but there could be other signs that she really has severe disease. So relying on hypertension alone or even proteinuria is not even safe based on the current knowledge that we have. Next slide. Now, interest in urine protein and creatinine ratio has urine protein to have some good positive correlation ratio with 24-hour urine excretion, with a correlation coefficient of about 0.758. A protein creatinine ratio of 0.9 strongly predicts significant proteinuria for more than 1 gram in the urine. The protein creatinine ratio can be used as a screening test, as a good predictor for remarkable proteinuria. However, it seems to be because it seems to be highly predictive of diagnosis to detect proteinuria over 1 gram, and it could be used as a rapid alternative test in preeclampsia patients, not so as not to delay diagnosis and also not to delay appropriate treatments. Next slide. So let's talk about some initial management principles. To successfully manage a woman with preeclampsia, it is important to manage her in appropriate environments such as high dependency units. And so institutions that have high volumes of cases must consider having high dependency units, and we know that they already have it. It is also important to establish appropriate monitoring protocols. Women with severe preeclampsia can now be monitored, just as we monitor the other women on the ward. There are 2 monitoring protocols that should be implemented within the high dependency unit system. The first one is what we call the emergency monitoring protocol. And then second one is the stable monitoring protocol. In emergency monitoring protocol, you want to, this is applied to women with, who have hypertensive emergency and who are very unstable. By this protocol, you want to make sure that you're monitoring the blood pressure, you're monitoring the pulse, you're monitoring the oxygen saturation every 15 minutes, while the fetal heart rate is being measured every 30 minutes, and then urine output every 1 hour. So this is the intensive phase of monitoring for a woman who may be very unstable. After the initial 2 or so hours, when the woman stabilizes, the woman can now be transitioned to the stable monitoring protocol, where blood pressure, pulse, oxygen saturation, and fetal heart rate will be measured every 1 hour, and urine output continue to be measured every hour. Next slide. So talking about acute control of hypertension, in order to ensure timely control of severe hypertension using appropriate dosage regimens of antihypertensives, there is a need to consider these patients in further categories. Even though we classify all patients with preeclampsia, with severe preeclampsia, when the systolic blood pressure is more than 160 and the diastolic blood pressure is more than 110. We do have situations where the blood pressure is really very high, situations where the systolic blood pressure is 200 or more, and the diastolic blood pressure is 120 or more. When we have such situations, we should classify them as severe preeclampsia with hypertensive emergency. When we have them just within the severe range, but with no hypertensive emergency, then we classify them as category A. If there is hypertensive emergency, we classify them as category B, severe preeclampsia with hypertensive emergency, systolic blood pressure more than or equal to 200, or a diastolic blood pressure more than or equal to 120. So there are a number of protocols that are used in our part of the world. So we have the hydrolyzing protocol, and we also have the labetalol protocol. Each of these can serve as a first-line protocol. I do know that Kolebu Teaching Hospital now is using labetalol protocol as their first line, with hydrolyzing protocol as their second line. So when you talk about hydrolyzing protocol, this is what has been suggested in one of the literatures. If the woman have only non-complicated or non-hypertensive emergency, you are hoping to start hydrolyzing protocol at 5 milligram bolus doses. IV hydrolyzing is administered every 20 minutes if the target BP remain exceeded. And what we are to do is to initiate emergency management protocols, give hydrolyzing 10 milligram bolus over the next 2 minutes. And if target values remain high, continue 10 milligram boluses every 20 minutes until you achieve your target value. And once you achieve your target value, you cease and maintain the woman on oral antihypertensive. The total maximum accumulated dose of hydrolyzing should not be more than 40 milligrams. So once you hit 40 milligrams total, and yet you are not able to achieve the target blood pressure that you want, you have to consider switching to another first-line drug, which likely to be labetalol. And if labetalol is your first choice, then you have to switch back to another medication. So let's look at the labetalol protocol. Talking about labetalol protocol, this is indicated only when there is no maternal history of cardiomegaly, no active wheezing, no significant history of asthma, maternal heart rate is more than 70, and the fetal heart rate is more than 120. This is because labetalol is known to depress cardiac function, and so therefore, if the heart rate is already low, you are likely to jeopardize the life of the woman. Again, you commence by starting the emergency monitoring protocol and initiate your labetalol protocol using the 10 milligram, which we call labetalol 10, 20, 20, 40 protocol. Labetalol 10, 20, 20, 40 protocol. We start with 10, and then when the target blood pressures are not reached, you now increase your dosage level to 20, and then repeat the 20 again, and finally go to 40 milligrams. And most of the time, you are able to achieve your target blood pressure. The maximum allowable dose for labetalol is 300 milligrams. For those with hypertensive crisis, IV labetalol can be started on 20-20-20-40 protocol. That is, somebody who has systolic blood pressure over 200/120. You want to start with slightly higher dose so that you can achieve reduction of blood pressure within a reasonable period of time. Again, if target values remain exceeded at a maximum dose, you consider another option. Next slide. If you want parenteral protocols, tight monitoring in an AG-like environment, some of the protocol, hydralazine and even labetalol, can cause acute hypotension. Labetalol also is known to cross the placenta barrier and has been found to bind to the eyes of the laboratory animal. Implication of this is not yet clear. However, the most important thing is that labetalol entering the fetal compartment can cause perinatal and neonatal distress, such as bradycardia, hypotension, respiratory depression, hypoglycemia, hypothermia, and so on and so forth. All these are easily reversible after the baby is delivered with supportive measures. And so it is not a big risk. Oral nifedipine. Oral nifedipine. A meta-analysis by Shika et al. And a systematic review has shown that oral nifedipine achieve treatment successes similar to that of hydralazine or labetalol, with only about 2% of them experiencing hypotension. And this is a huge advantage. And this is what has been adopted by my institution, Greater Accra Regional Hospital, as our first line. Because of the simplicity of use, the fact that midwives can be allowed to take ownership of the initial management using tablets, nifedipine to control blood pressure. The protocol is very simple for them to remember. Plain nifedipine protocol only for patients who can accept oral medications, patients who are conscious and well-oriented, who can take the oral medication. So that also becomes a downside. If somebody is restless and a bit confused, you cannot rely on the patient using plain nifedipine. Nifedipine has been found to be effective and safe. The dose regimen is very simple, 20 milligrams every 20 minutes for 5 doses. And once you achieve the target blood pressure, you send the patient, transition the patient to ordinary oral antihypertensive medications. Again, you monitor the vitals very acutely. Next slide. In terms of prevention of fits, magnesium sulfate remains the gold standard. The exact mechanism of magnesium sulfate is still not very known, but we do believe that it reverses cerebral acute cerebral vasoconstriction. It causes cerebral vasodilatation. We also think it binds to some central excitatory receptors and then reduces excitability of the neuronal pathway. But the most important thing that I would like to talk about as far as magnesium sulfate is concerned is the fact that currently there are some studies going on that are considering, next slide, there are some studies going on that are considering lower doses and then loading doses only regimen. So it means that we know that with the older regimen, you give an initial loading dose and then you continue with maintenance dose. There are some studies going on to consider only administering the initial loading dose. There are also some studies that are going on to administer a lower dose of magnesium throughout the cycle. Now, most of these come from studies with very poor quality. The studies are of poor quality. We really need further studies in this area. And it will be interesting if any of our advanced centers can consider some of these studies to come out with a proper guideline as to whether magnesium sulfate dosage regimen can be varied in our part of the world. Next slide. When it comes to delivery, the standard recommendation for management of severe preeclampsia has been to deliver this has been the standard recommendation. Once a woman comes with severe preeclampsia, deliver the woman. For those who have come with late onset severe disease, let's say the woman comes with 36 completed weeks, 37 completed weeks, immediate delivery is justified in all cases after the initial stabilization, because we are sure that the baby will survive. So there is no question at all. If the woman comes with late onset mild disease from 32, maybe gestational age from 32 to 37 weeks, the HYPITAT study randomized controlled trial investigated the effect of immediate delivery versus expectant management between 34 and 37 completed weeks. And the findings were a bit mixed. There was the realization that if you do conservative management, you have a higher chance of having a baby who will have a better chance of survival, but at a small risk to the mother. So therefore, you have to have a balanced situation where you are sure that you are controlling the environment, controlling the blood pressures, and making sure that the mother is not up to any risk. However, also, if you opt for immediate delivery for these non-severe cases, late onset non-severe cases, if you consider immediate delivery, you may increase the risk of neonatal respiratory distress syndrome. Let's say a woman appears 34 plus few days and is carrying has developed mild preeclampsia. If you rush to deliver such a person, there's a higher risk that the baby may have some respiratory distress syndrome, whilst the risk to the mother may not be very high. So it is important to know that this trial was not actually specifically powered for neonatal endpoints, and so show a clinically important, non-significant benefit to the mother. Therefore, further evidence is required, further studies. There are studies currently ongoing. There is a Finnish study which is also ongoing to look further into how preeclampsia after 34 weeks, which is regarded as mild, can be managed to improve outcomes to both mother and the baby. Next slide. For those pregnancies that are less than 26 completed weeks with severe preeclampsia, perinatal outcome is often very poor, whether expectant management or immediate delivery is carried out. So therefore, unless under certain extreme conditions, we even don't advise the woman to be taken through expectant management, because the chances are that the outcome will eventually not be good. So the gray area actually, which concerns most clinicians, is between 26 and 34 completed weeks. Many experts and consultants sometimes try conservative management under certain conditions, because you have a woman who is maybe 27 weeks, and you are thinking that if you are able to delay the pregnancy for about 2 weeks, this woman will have the baby will have a better chance of survival. The question is, what are the factors that should guide your decision-making under these circumstances? Next slide. The advantages of expectant management under these gray conditions is that you are able to prolong pregnancy and improve perinatal outcome. There is a data collection that we did at the Greater Accra Regional Hospital, and we realized that 1 week prolongation of pregnancy from 28 weeks under good conditions, from 28 weeks to 29 weeks, can increase perinatal survival from 36% to 65%. And then a 2-week prolongation of pregnancy from 28 weeks to, let's say, 30 weeks can also increase perinatal survival to 71%. So when you have a patient, let's say, at 28 weeks and has severe preeclampsia, but conditions are favorable, and you think that you can manage this woman for 2 weeks, then you are likely to increase the chance of survival of the baby to about 71%. Complications can result if monitoring systems are not adhered to. So studies have shown that expectant management is possible under certain circumstances. But most of those studies are done in the developed world. And we cannot therefore also translate studies that are done in developed world directly into lower middle income settings, because their conditions, their monitoring systems, their NICU systems, and all these systems are different from our system. So we cannot directly translate. So the question therefore is, what are the parameters that should guide clinicians to make a decision to say that we want to subject this particular patient to some conservative management, or we want to deliver because of his condition? This takes us to the risk prediction model. Increasingly, risk-based medicine is employed to address resource problems and improve outcomes, as reflected by a rapid growing field of prediction research. An individual's predicted risk of an adverse outcome will allow the clinician to triage the patient into either low risk, moderate risk, and high risk, with corresponding options for intervention, either to prevent or treat the disease condition. Thus, risk prediction models can guide the organization and provision of quality healthcare to the right person at the right settings and at the right moment, all of which are crucial, especially in resource-constrained settings like ours. There is the need for predictors of adverse maternal and fetal outcomes during preeclampsia to guide our decision-making. This is very crucial. So one very important study that was conducted, Pre-eclampsia Integrated Estimate of Risk. This study, which is referred to as the full PS and then the mini PS, look at outcomes of mother and baby when certain parameters were taken into consideration. Under full PS, gestational age, presence or absence of chest pain and dyspnea, oxygen saturation level, platelet count, serum creatinine, serum aspartate aminotransferases were considered. And then in the mini PS, only the parity, gestational age on admission, presence of headache or visual disturbances, chest pain, dyspnea, presence or absence of vaginal bleeding, systolic blood pressure, and district proteinuria. These are the parameters that was taken into consideration with the full PS and then the mini PS. And these are the findings from the mini PS, from the full PS studies. Though all symptoms tended towards positive correlation with adverse outcome, only the symptoms of right upper quadrant or epigastric pain and chest pain and dyspnea were found to have moderate predictors of combined maternal and perinatal outcomes. Even these are symptoms that we clinicians, when we see them, we are rushing to deliver them, but they have only moderate prediction of combined maternal and perinatal morbidity. Lab parameters that are significant are these three: the creatinine level, the platelets count, and then transaminases. They were the most predictive of adverse outcome. So these are the lab parameters that we should be looking out for before we can decide that we want to commit a patient or a woman to conservative management or an immediate delivery. So what are the relevance? The problem with these studies, again, are the fact that, next slide, please. The problem with these studies are the fact that, again, most of them were not conducted in our environment. The peer was not validated in Ghana, not focused in the particular gray zone, which is currently of our interest between 26 weeks to 34 weeks. Preeclampsia remote from term is only 25% of severe preeclampsia. Prediction score are important, are going to be very relevant moving forward because they can guide clinical decision making, they can provide optimal timing for delivery, and they can help us select cases that are eligible for conservative treatment. And above all, they can reduce adverse maternal and perinatal outcomes. In Ghana here, there is a study, and that is the SPOT study. And this is a multi-center observational study, which is currently ongoing in 4 institutions, including Kolebu Teaching Hospital, Reed, La, and Koforidua Regional Hospital. And the aim of this study is to externally validate the full PS and the mini PS prediction model in order to develop a simple, user-friendly, numeric severe preeclampsia adverse outcome triage score to assist us in making decisions as to which patients we should manage conservatively, which patients we should deliver immediately. The whole aim is to develop a score chart, like as we have in the panel here. We have the red after the patient is classified. We'll be using clinical symptoms and also laboratory findings. You could classify the patient as red, or classify such patient as yellow, or classify the patient as green. So red patients would then mean that yes, she has severe preeclampsia, but she's in the red zone. It means that she needs immediate delivery. If the patient is yellow, it might mean that you may have some small time to mature the lungs or repeat the lab to see how the labs are trending. And if the patient who is severe preeclampsia but classified as green, it means that such a patient can be subjected to conservative management for a week or two whilst you monitor the patient and recategory the patient. So to quantify the relationship between fetal, there are other objectives of the spot study, which I wouldn't bore you at this point in time. Let's go on to the next slide. So by way of summary, I want to stress the fact that there are a lot of pitfalls in the management of preeclampsia, especially in our part of the world. Even though early onset type constitutes a smaller ratio, as we have earlier on alluded to, only 25% of time, it poses greater challenge to clinicians and also poses more disappointment and pain to the patient. It also contributes significantly to perinatal mortality and morbidity. It imposes a huge socioeconomic loss to families. We still don't really understand the full ramification of this condition. There is a need for more focused research, especially if there is any research that we should be fully, that all hands should be on deck on. It should be studies and research to understand what happened in early onset type of preeclampsia, because this is where majority of fetal wastage is. Okay, and this is where disappointment to the mothers. Okay, and this is where severe morbidity, severe mortality and mortality can occur. This is where intensive research should be conducted. The time to act is now. Thank you very much for listening.
Thank you very much for your presentation, and thank you for highlighting so many important points, both to you, Dr. Frenyo, and Dr. Adebonsafo as well. We have about 15 minutes for a Q&A session. Who can I invite to ask a question? You can indicate if you have a question either through the chat or by raising your hand, the function that Zoom provides. I see many people already commenting on your presentations. I see Dr. Ishaku from Nigeria has a question. Salisu Ishaku, I will, if you would like to ask your question, you can. Just a minute, I think your phone, your audio is still muted. Okay, you should be able to ask your question now, Salisu.
Yeah, can you hear me?
Yes, we can.
Oh, thank you, Dr. Sofrenyo and Kwame, for your wonderful presentation. I just have one quick question. You all highlight the challenges in the prediction and also in the management, which is understood. But given the challenges and the burden of preeclampsia in this region in general, Kwame, can you just advise us? I know there are many healthcare workers and obstetricians listening to you. Can you tell us what we can do at the minimum to start doing something? What should we be doing to anticipate preeclampsia? And then probably Dr. Sofrenyo can tell us what can we do if we have some certainty or predictive value that this may likely occur. What do we do next? Just something to start working with. I know that we don't have ideal. We are struggling to find out what are the best thing to do, but what can we do just practically in the sub-region, Africa, Nigeria, Ghana, Cote d'Ivoire, and so on? What can we do just to predict?
Okay, Salisu, thank you for the question. First of all, let me point it out here that Salisu is one of the authors of the International Society for the Study of Hypertensive Disorders, the paper that I talked about most. And if you look at it, they recommend that we use mostly the clinical history because, especially in our part of the world, where we don't have people more experienced in even doing the umbilical uterine artery Doppler, which is even less invasive, we cannot do some of the big things we mentioned, like placental growth factor levels and all that. And that's why the work of Dr. MP is very important. Basically, they use clinical parameters or characteristics of the mother. And I think this is what probably we should be thinking of most, because for our purposes and for our environment, we don't have the luxury to do the very detailed one. We should rather get more experience in the clinical factors until we get opportunity to add onto the model with the more invasive markers. So as I said, BP monitoring at the booking is very important, and we should use that most. In one of the studies, it was mentioned that diastolic blood pressure of 75 and above at the time of booking can really be something to use in terms of prediction. So if you use that in addition to the history, that would be very important in trying to kind of categorize those who are likely to develop preeclampsia in the current pregnancy. So I will give the opportunity for Dr. Sofenyo to also respond to that, the other side of the question. Thank you very much.
Thank you.
Thank you, Salisu, and then thank you, Kwame. I think that I will go more with Kwame, what you said, that at this point in time, I don't think we have the infrastructure now to try to do the invasive investigations to try to predict. So I will also go more from the work of Dr. Entry, that once the patient arrives at the antenatal clinic, this can be done at the district hospital level. Once the patients arrive at the antenatal clinic, a risk classification of the patient should be conducted. And I have in mind some of district hospitals, we are thinking about it with Dr. Entry, that we will work with the district hospitals. Once patients arrive, we have a tool where the risk status of the patient is determined based on the model that was described. And then the patient is classified as high risk, intermediate risk, or low risk. And the high risk cases are then referred to the higher, to maybe the specialist hospitals like Kolebu Teaching Hospital and the Greater Accra Regional Hospital, so that a consideration for soluble aspirin and probably low calcium supplementation can be done in order to prevent development of preeclampsia. So for us as at now, this is the only way out, and this is what we should be doing. We should take advantage of the model. At least we'll be able to prevent about 50%, because from Dr. Enchi's from Kwame's presentation, we could be able to prevent about 50% if we use clinical correlation model. We could be targeting or reaching about 50% of the patients who eventually will develop preeclampsia. Thank you so much.
There are two questions asked about the prevention that you just mentioned about aspirin and calcium. The first one is about when the indication to give aspirin to high-risk women and what the dosage is that you would recommend. And the second question that focuses on both aspirin and calcium and what the role is of calcium in preeclampsia prevention. And in the meantime, we'll add a few Cochrane systematic reviews that also answer some of these questions for your background information if you're interested. But Dr. Sofenyo or Dr. Adebonsafo, please answer the question based on your available knowledge.
Okay, Dr. Sofenyo, I think you can start your own. That is the first one. Oh, I can go on. Yeah,
so the first one was about aspirin. What is the indication and what is the appropriate dose?
Okay, so aspirin, the indication is when you have major risk factors for preeclampsia. And if you look at the presentation that I gave, you'll see that somebody who had a previous early onset preeclampsia is one. If somebody has a chronic hypertension, it increases the chances of superimposition. And so that's also another. Pre-gestational diabetes, not gestational. And then maternal obesity of about 30 and above. When you have more than 25, it's mild. I mean, just overweight, that is not really a major risk factor, but 30 and above, and somebody with chronic kidney disease, antiphospholipid syndrome, and especially if you think the person developed early onset preeclampsia that was severe, that means that if you look at the pathophysiology, thrombotic aspect, or when there's thrombosis, I mean, that is where these things comes in. So it's better we look at those ones, but some of the minor risk factors, the International Society doesn't really recommend us to use. It is recommended that if you can use 150 milligram, that is the best. Previously, people have been using, or we have been using 75. Recent studies are showing that if you use 150, that is probably the best. And so we should be kind of trying to move a little up to start using. It's not going to cause any hemolytic issues when you use, because you can actually stop a week or so before delivery. So that will be the answer for the aspirin and then the risk factors.
So let me talk about calcium supplementation. From some meta-analysis that has been conducted, and one name that has done a lot of extensive work in this area is Hoffman. Hoffman has done a lot of extensive work in this area, and he has found out that where dietary calcium intakes are low, the incidence of preeclampsia is higher than areas where dietary calcium intake is higher. And so based on that, a lot of studies have also come out to show that calcium supplementation actually reduces the risk by about 50%. And it's not an absolute reduction, but it is something that is better than nothing. And so the consideration is that once the woman falls in a higher risk, like as we said, all the risk categories that Kwame has spoken about, the woman falls in those risks. The woman may also be eligible for the soluble aspirin, as has been given, but it would be prudent to also add add calcium to such a package for the woman who has been found to be in a higher risk, particularly if the woman is in settings where calcium intake are low, especially in our part of the world. We are not sure. We are still looking. I'm still looking for studies to tell us what is our calcium intake. We know that those who are at the coast, they may have a habit of taking a lot of crabs and food that may contain calcium, but the documentation is not yet solid. We want to appeal to nutritionists, people who have nutritional background, public health physicians should go into this area so that we can understand what is our risk in Ghana and also our risk in West Africa. Are we people who already take adequate calcium, or are we relatively calcium deficient? This is an area that needs to be further scoped. Thank you very much.
There is a follow-up question about the recommended calcium supplement dose. If you allow me, I can also answer it from the literature recommendation available. So the WHO recommends supplementation of calcium between 1.5 and 2 grams per day, but this is quite a lot for women if you would consider the bulk of calcium or the tablets that you would need to achieve this essential calcium. Justice Hofmeier, who Dr. Sofrenia just mentioned, has done a lot of work on lower dose of calcium, and he suggests that, or the studies that have been published on lower dose suggest that between 600 and 800 may also suffice, but it also depends on the background or the baseline intake that women already have. But the minimum effective levels is one of the key questions that we do need to answer as a research community, because the lower the dose, the easier it will be for women to take it. And huge blocks of chalk is just not very women friendly. So lower doses is preferable as long as it's effective. I see.
Yeah, there's a question on uric acid. Dr.
Yes.
Sofania, would you want to take that? Uric acid.
Uric acid.
Yes.
Uric acid has some role. Uric acid has some role. The studies have shown that uric acid may be important in the initial diagnosis, but it's not important in prognosticating whether this woman is a high risk or the disease is worsening. So once the uric acid is high, yes, you are classifying that patient, even if urine protein is negative, but uric acid is high, it's an indication that there is some end organ derangement. But you cannot rely on uric acid to classify that the condition is becoming worse. Most of the time, you see the uric acid in the next visit, the uric acid is high, is climbing up gradually. It does not necessarily mean that you have to rush for delivery. As I said earlier on, from the studies that were done, the three important laboratory parameters that should be considered in and then the platelet indicators that should be taken into consideration in making a decision. If platelet levels beginning to drop or the transaminases are rising, especially if they rise to more than 2 times the normal, the upper limit of the normal range, and also if the creatinine clearance or the creatinine level is also rising, then that is a patient that needed to be delivered immediately. Thank you very much.
Yeah.
Dr. Sofania, there are a few questions related to the protocols that you introduced, the protocols of the Greater Accra Regional Hospital.
Yes.
I will highlight a few questions. One question from Daniel Pong is to throw more light on Nifedipine protocol for severe preeclampsia management. The second question I see popping up is what to do if you exhaust the 3 current options, Nifedipine, labetalol, and hadrilazine. And yeah, so those are the 2 first questions. So can you recap the Nifedipine protocol for severe preeclampsia management? And what do you do if what is the next step after you exhausted the Nifedipine, labetalol, and hadrilazine options?
This is an area that I don't even want to go to. We pray that by the time you try any of these, you try all these options, the blood pressure should be coming down. But occasionally, it happens that you have finished the 3 options. Option 1, hydralazine. Option 2, labetalol. Option 3, Nifedipine tablets, and still the blood pressures are not coming down. You probably may want to throw in the towel at that point in time and deliver the woman. Nifedipine protocol is what we have adopted at the Greater Accra Regional Hospital, as I said earlier on, as our first-line medication. And the reason for choosing that is that it's equally effective like hydralazine and labetalol, but very cheap, very easily affordable, and the midwives are able to use it on their own. You know, at the Greater Accra Regional Hospital, one of the things we do is that we have what we call the midwifery-led care, where the midwife can receive a patient severe preeclampsia, classify the patient, and if he sees that the patient has severe preeclampsia, can administer the first dose of Nifedipine even before the doctor comes in, because we don't have so many doctors like other centers like the Kolebu Teaching Hospital, where the doctors are all over the place, and then they will be there to administer labetalol or even hydralazine. And so that is why we went for this choice. And we feel that other district hospitals, and that is how we mentored the district hospitals who are under us, we mentored them to also use the Nifedipine protocol. It's so easy to use. Tap Nifedipine 20 milligram every 20 minutes for a total of a maximum dose of 5 doses, a maximum of 5 doses. And most of the time, by the time you get to the 5th dose, the blood pressure is beginning to come down. If the blood pressure don't come down, you're at liberty to go to your another first line, which will be hydralazine or labetalol. Most of the time works.
Concurrently, so because it's another question that someone posed, can you give both Nifedipine and hadrilazine concurrently?
No, we rarely, and I don't have any experience of combining the 2. If you finish the Nifedipine protocol and you are unable to get to your blood pressure target, then you can switch to either hydralazine or labetalol, just as you will give hydralazine, and if you don't get to your target and the blood pressures are still high, you may want to switch to labetalol. But the two are not supposed to be given concurrently. If you don't take time, you may experience severe hypertensive crisis that can lead to the death of the baby and even can compromise the woman. And so it would be best to try one fully, give one to a maximum dose. If there are no outcomes, if there are no target outcomes, then you switch to the other one.
There is also a question that is a very nice illustration of what the value is of including women's voices who've experienced preeclampsia. The Chief Executive Officer of Action on Preeclampsia Ghana asked the following question: Nifedipine gives some patients severe headache after intake. In that case, what are the options for them?
Please come again so that I can hear it well.
So one of the Koiwa Korlarbi of myself, she asked whether what we can do if patients experience severe headache as a side effect of nifedipine. What are the best options for them in that case to manage side effects of headache with nifedipine?
If they experience severe headaches as side effects of the medications?
Yes, exactly.
Is that it? Okay.
Yes, question.
Well, so as far as nifedipine is concerned, when the patient, unfortunately, headaches is one of the side effects of nifedipine. And if you start and the patient experiencing severe headaches, then I'm afraid you just want to transition to another medication. There is no other option. You may just want to transition to another medication, probably labetalol or hydralazine. Yeah, I know Kolebu Teaching Hospital, labetalol is their first choice. There is one aspect of the management that I didn't emphasize in this presentation, and that is psychological support for women who go through severe preeclampsia. I want to encourage all of us clinicians not to put this at the back burner. It is so very important that whilst we are trying to manage the physical person, we should also be considering their psychological state. It is a very devastating condition. And unless we also provide that aspect of the care, our outcomes are not likely to be holistic. And so we expect that all bigger institutions to involve the clinical psychologists in the care of such patients. Thank you very much.
Very important point, and I will share in the chat the link to Salim Bangabi's lecture on World Preeclampsia Day, in which he also talks about the mental health of women who've had hypertensive disorders of pregnancy, because it alludes to this point. Dr. Bunsafo, did you want to add?
Yes, I just wanted to add that I think the choice of nifedipine is not out of range, because most of the randomized controlled trials actually listed nifedipine, labetalol, and hydralazine as kind of equally effective. And so that's what we are trying to propose, that in Ghana, for instance, where nifedipine is a little cheap compared to labetalol and hydralazine, and it can easily be given by less trained people, maybe we should be thinking about moving towards that than that. And that's part of the, at the end of the sports study, that will also be analyzed, and we can come out with concrete decisions on that. And so we should be thinking about using that most of the time. Hydralazine is very difficult. Most people are trying to run away from it because of the severe hypertension that can occur in the fetal distress. And just to add to it, yes.
This is the last question because of time before I will wrap up this meeting, but it is important because of the consequences if we do not think about this. Isaac Abu Bakar asked whether it's necessary to bring down the blood pressure before going for C-section if indicated. And this ties into the stabilization of patients. Could you comment about your recommendations to stabilize a patient before cesarean section?
Yes, definitely. You have to stabilize the patient before, because sometimes if you give a spinal, for instance, it can suddenly drop the BP, and you may have sudden reduction in blood supply to the brain. And people who may have early onset of or early CVA, reduction to the blood supply to the penumbrum of the brain area can cause more damage. So you need to maintain it at a lower level until you take the patient to theater than to just take a patient who has a very high blood pressure to theater. That may create some problem. If it's not possible, you may have to then think about a GA, which you have to get other senior members involved to be able to help with the delivery. Otherwise, you can have bad outcomes.
Thank you. Dr. Frenia, do you also want to contribute your perspectives on this question of stabilization? Oh, you're on mute, I'm sorry.
I do agree with Pami. Am I coming across now? Yes, that it is important to optimize the patient's condition before you attempt to deliver. We'll be talking about delivery in another delivery and the modes of delivery in another webinar. But it is very important that the patient is in the best of shape before we go for cesarean section, or if we are aiming for vaginal delivery, that the patient is in the best of shape. And optimizing the patient does not only mean the blood pressure, making sure that the chests are clear, that is the cardiopulmonary system, everything is in a state that the patient will be in a position to stand anesthesia or to stand the stress of labor before we subject the patient to these things. That way, the outcomes are likely to be better than if we write a patient who is unstable to theater or subjecting her for labor, for vaginal delivery. Thank you very much.
Thank you. And as you can see, we have reached the end of this first webinar. A few things for the wrap up before I proceed to thanking you. So this webinar is freely available for everyone who wants to attend and listen in. But in order to receive CPD accreditation, there is a fine or fee attached, and this can be applied for and paid for with this information. I'm pulling up a poll right now to indicate if you want to make use of this so that we also have a track record of your attendance. And this is what we will use as a basis to submit to CPD. So if you could please fill out the following very short questions, that would be very helpful. First question is, I would like to receive CPD credit for the attendance. If you're not interested in receiving CPD credit, that's absolutely fine. You're very welcome to join this session and the future ones. And please indicate it here on the poll right now. I don't see anyone has voted yet. Are you experiencing any challenges? All the co-hosts cannot see the poll, by the way, only the people who are attending the meeting as participants, in case the co-hosts were wondering. I don't see, is everyone able to see the poll and answer it? Okay, we'll also circulate this information after. Okay, see people commented. The number of points I'm referring to my fellow organizers to be able to answer this, or to ask if they're able to answer this question. Okay, a few more seconds to answer these questions, Now we'll end the poll. Okay. There is a feedback form about this session in order for us to, first of all, improve the organization and to learn from this first experience, but also to think about future questions and future topics we may want to cover. And please note the dates of the next two seminars. The next one is August 28th on the management of hypertensive disordered pregnancy during delivery and postpartum, and the session on September 25th will be on the ethics and referral pathways, and both will be at the same time, 5 p.m. In Ghana. So finally, we'd like to thank, first of all, our speakers of this evening, Dr. Adobonsafo and Dr. Sofrenio. And I would like to thank also the organizing team for the work we together put into getting this webinar together. If you have any outstanding questions or things you would like to provide feedback on, please do so through the forum or by emailing us. We're very happy to hear your thoughts, and we can also follow up on any questions by email or link you to the speakers if you want to.
Thank you very much, Joyce, for coordinating all this and making it so successful. Thank you.
Thank you. It's my pleasure.
Yes.
If there are no other questions anymore, I am hereby closing the meeting, and I hope to see you next month again. Thank you all for joining today or this evening.